Bonjour. So I'll be talking about performing graft surgery with eye syndrome. These are my disclosures, they don't relate to this topic itself. Okay, so iridocorneal endothelial syndrome is a syndromic condition made up of three distinct entities: essential iris atrophy, Chandler syndrome, and Cogan-Reese. And they all basically have the component hallmarks of iris involvement, glaucoma, and endothelial disease. Most of you will be familiar with these clinical features of PAS, iris nodules, and atrophy of the iris. Of course, the atrophy of the iris occurs when you get a hole formation due to a pulling of the membrane surface across the other side of the cornea. So as the membrane of the endothelial cells migrate along the surface, you get a pulling of the iris, causing hole formation in the opposite side. Of course, the hallmark of the condition, or the pathognomic changes in the endothelium itself. And what you see is a reversal of the dark light reflex. And these are called eye cells. You can see them quite nicely here on the specular microscope. It's more common in females compared to males. Often the patients don't have any family history, and characteristically the endothelium in the other eye is normally completely normal. There may be some sort of viral etiology related to that. The pathology of eyes is a basically abnormal corneal endothelial cell migration, because there's a loss of contact inhibition of the cells. The cells will then basically migrate. You get a proliferation as an ectopic sheet, as a membrane. And what happens is, as it proliferates over onto trabecular meshwork, it obviously causes glaucoma from PAS. The PAS can pull on the iris surface and give you the pseudopolychoria and choroidopia and the iris nodules, so because you get a difference in the iris stroma. If you look at the three different types that I basically showed you itself, you'll see that corneal endothelial involvement and corneal edema is invariably present in all these basically forms of eye syndrome. So it's likely that as a corneal surgeon or a glaucoma surgeon, you're going to basically come across these patients. When you have to deal with these patients, there are basically three clinical scenarios, and I'll show you how we can basically deal with them individually. So all patients need control of their intraocular pressure before they undergo transplant surgery. They must have assessment of their endothelium with specular microscopy and pachymetry. And they're basically three clinical entities. One is edema with a normal pupil, as you can see over here. One is edema with choroidopia. And one is edema with pseudopolychoria. And these all have to be dealt with slightly differently when you're performing the surgery. The options are, obviously, you can reduce try to control the pressure. You can give hypertonic saline to help with the edema initially. And the surgical options have traditionally been penetrating keratoplasty. Of course, it's technically easier to perform. You can reconstruct the anterior segment, and there's established publications in this area. Performing EK in these procedures is more difficult. There can be some issues with the air, because the iris is often atrophic, especially if there are extra holes there. Pupil reconstruction is more difficult in these kind of cases, and there are very few publications. There are only a handful of cases reported in the literature. The first was from the Price Vision Group, and then after that there have only been a single case report in the literature of EK in these cases themselves. So you see two procedures going on this side over here. One is with a normal pupil on this side. One is with an abnormal pupil. Now you can see here, after the phaco, in order to correct the choroidopia, the difference in your surgical technique is that you must basically go and strip off the descemet membrane from the angle to correct the pupils. You can see the descemet membrane coming off over here in one stripping, and as it comes off, what you'll see is that it's actually attached to the iris surface as well. So this is a much larger decimate stripping than you'd perform in conventional EK surgery. The normal surgery you can do basically pretty much in the standard way. The iris may be a little bit more softer, but generally, essentially, it performs in a normal manner. But here, as I do the stripping, it's much larger than you would do in a standard EK procedure, and sometimes you have to use intraocular scissors to remove the iris basically from the surface, because this membrane is ectopic. If you do not remove it, the pupil will still be distorted after the surgery itself, and the patient will get left with a distorted pupil. The most difficult scenario, however, is a case like this, where you get pseudopolychoria. There's PAS all the way around, especially in that count thing, there's visual acuity. It's a very severe case of essential iris atrophy. In this case over here, again, because you've got severe choroidopia itself, and in order to do the cataract surgery initially, I thought, okay, we'll use some iris hooks over here. You can see as the hooks go in, as I'm trying to basically retract them across the membrane itself, you'll see the hooks themselves don't actually attach to the end of the pupil. And the reason why is that the ectopic membrane has actually passed across the surface of the pupil. But this membrane itself, if it's quite advanced, it will actually go across the anterior chamber itself. So what you need to do is make a hole in this basically ectopic decimated membrane with endothelial cells on it, put the hooks into place, and then perform your cataract surgery. The issue is that you're then performing your cataract surgery without a desmoid membrane intact. So if you take a long time to do the surgery, the cornea is definitely going to haze up. And as the surgery basically goes on, you need to do the phaco quite quickly. Otherwise, basically, you'll start losing your view of the intraocular structures themselves. Once you basically have removed all the stripping of the desmoid membrane, I strip all the way around as I do in the usual manner, and then you basically perform your EK surgery in the usual way. So post-operatively, this is what the patient looked like. So initially at 6 days, 6:45, and 6:21. So the cornea cleared quite nicely. You can still see the effects of correctopia, but she got a nice round pupil because we stripped away all the basic desmoid membrane. So as you follow them up longer term, 6 months, pretty good. But you have to watch them very, very closely because, of course, these patients still have issues with glaucoma from their PAS, and the pressure will go up. The pressure went up to 38, even though she's already using steroids once a day. She subsequently underwent a trabeculectomy with mitomycin C, which is our preferred procedure of choice following EK surgery. Her pressure came down, and visual acuity was maintained. I just saw her recently. She's now 4 years post-operatively maintaining good visual acuity and intraocular pressure. So last year, in collaboration with the Price Vision Group, we published this paper in AGO, where we did a retrospective series of cases. This is the largest published series of eye syndrome cases, 29 eyes, 17 PKs, 12 EKs. So we wanted to do a comparison between the two groups. The follow-up was 7.5 years for the PK group, 4 years for the EK group. In total, 38% of the grafts failed by the follow-up time, 64% in the PK group, 36% in the DSET group. There was no significance in difference in graft survival between the EK and the PK. So, of course, EK surgery should be attempted in these kind of patients. If you look at the failure cases, 9 out of 11 were basically due to late failure, only 2 from immunological rejection. Failure was more common in eyes that had pre-PK glaucoma drainage devices, as Dr. Price mentioned yesterday. IOP escalation was required in 38%, out of which 10% required additional surgery, and our surgical procedure of choice is trabeculectomy. Preoperative glaucoma surgery was less likely to require increase in intraocular pressure medication, so if they had a trabeculectomy pre-op or they were controlled on topical medication, it was less likely they needed to require medication post-operatively. So in conclusion, eye syndrome cases will have a combination of corneal and glaucoma pathology. It's important to show adequate intraocular pressure control before corneal transplantation. Variation in surgical technique of EK is required with respect to the desmoid membrane stripping to ensure adequate pupil ovalization post-operatively. Graft outcomes for EK are equivalent to PK, but of course you have all the significant benefits that we all know of the EK technique over PK itself. And there is a 38% chance of intraocular pressure escalation required post-operatively, so you must watch these patients long-term with the required follow-up with a glaucoma surgeon or manage the glaucoma yourself. Thank you for your attention.
Thank you.